Good evening, everybody. And thank you very much for joining us for this, the third of our series of live free webinars, which are organised here by the team at the UK GIM. My name's Dr. Adam Weldon, and I'm a hospital consultant involved in the care of patients who present to the acute medical on-call. Our goal at UK GIM is to provide high quality but inexpensive training for doctors and allied health professionals who are involved in the care of general medical patients. Our way of doing this is to provide a series of free webinars which are aimed at providing training for common presentations to the medical on-call, and we'd be really keen to hear from you if you have any suggestions for topics that you think would be really helpful to help with your CPD. We aim to put on a conference next year called the UK General Internal Medicine Conference. As I'm sure you're aware, face-to-face conferences are becoming increasingly difficult, and we've been monitoring the developments really very closely with the COVID-19 pandemic. And of course, the safety of our colleagues has to be paramount. And so I'm very pleased to announce that we've decided to migrate the face-to-face UK General Internal Medicine Conference now to a virtual platform. And that will be held on the same dates, the 2nd and 3rd of March 2021. As part of this, the team here have been researching multiple IT platforms, and we're really very confident that we can offer an interactive learning platform for the delegates, so you can still interact with the excellent speakers that we have. And of course, every cloud has to have a silver lining, and so as part of this, we're able to actually reduce the price of our super early bird tickets, and we feel we're able to do that by £100. So our super early bird tickets are now £59 plus VAT, which is an amazingly good value for a 2-day conference. Our UK GIM conference has recruited some fantastic speakers from all across the general internal medicine take, all of them experts in their field. What we plan to do is to run multiple live streams of lectures. So you'll be able to pick and choose the stream that you wanted to go to for that particular lecture time, and then perhaps move into a different stream after that. We plan to repeat some of the lectures across the 2 days, and so if you miss the interactive opportunity, you'll be able to catch up with that at a later time in the conference. And then following the conference, we'll have recorded material available. Unfortunately, you can't interact with that in the same way, but we'll aim to have that available for people who have been delegates as well. What we hope is that delegates can construct their own bespoke program of CPD. And if this would be of interest, then please do have a look at our website, which is ukgim.com. More importantly, moving on to this evening's webinar, which will last for approximately an hour, we have a presentation from Dr. Chris Holroyd. Dr. Holroyd's a consultant rheumatologist at Southampton General Hospital, and Chris dual accredited in both rheumatology and in general medicine. Dr. Holroyd is a consultant lead for the biological therapy service at Southampton, and was also awarded a British Society of Rheumatology Outstanding Best Practice Award. Chris has also got a very keen research interest and has worked at the Medical Research Council. I'd very much like to thank Chugai Pharmaceuticals, who have very kindly provided sponsorship to help the team here at UK GIM so that we can continue to provide free education. As part of this webinar, there's going to be the opportunity to ask questions to Dr. Holroyd following the presentation, and I'd encourage you to use our chat function for that. If you put questions into the chat function, I'll try and pull together any themes which arise from that, and try and ask questions as they come up to Chris. We'll save the questions to the end. So the presentation will be around 35 to 45 minutes with the opportunity for questions. So without further ado, I'd like to hand over to our guest speaker this evening, Dr. Chris Holroyd. Thank you very much.
Thank you very much, Adam, for that introduction. I'm just going to share my screen there. So as Adam said, I'm a rheumatologist at the University Hospital of Southampton, and I'm going to be delivering this webinar today looking at advances and challenges in the management of rheumatoid arthritis. So rheumatoid arthritis is the most common autoimmune inflammatory arthritis that we have. Affects around 400,000 people in the UK, and it has a prevalence of around 1%, so it's common. As with all of the autoimmune connective tissue diseases that we see, it's more common in women, has an incidence of approximately 12,000 people per year, and it peaks in the sort of 4th to 6th decades. It's an expensive disease to manage. So if you add up the costs of medication plus outpatient appointments plus orthopedic input plus disability, it costs the UK economy up to £5 billion per year. So when a patient with rheumatoid arthritis presents to us in rheumatology, often there's not the deformity that we've all come to associate with this condition. So as you can see on the picture on the left there, patients may present with some puffiness around the PIP joints, but no overt deformity, and x-rays taken at that time hopefully will not show any structural changes. And it's very much our job as rheumatologists to prevent the deformities that we will all have seen and witnessed firsthand from happening. So things like swan neck deformity, Boutonniere's Z thumb, ulnar deviation, and x-ray changes such as the ones we can see on the right there, where this patient clearly has extensive damage to both the wrist and the MCP joints with dislocation. And we know that once patients have got to this stage, then really medical therapy isn't going to be that effective. And in addition, although this is called rheumatoid arthritis, we know that this is a widespread inflammatory condition. So it doesn't just affect the joints, it can affect pretty much any organ in the body, as you can see on this image here. More common involvements are things like osteoporosis, cardiovascular disease, which we screen for, but also things like interstitial lung disease, pulmonary fibrosis, and ocular disease, particularly episcleritis and scleritis. And then more rarely these days, things like vasculitis, secondary amyloidosis, and Felty syndrome. And these have probably reduced in incidence because of the advances in therapy that we have. So here we can see the kind of historical treatment of how rheumatoid arthritis would have been treated really in the 80s and 90s. So it was a very conservative approach. So starting at the bottom of the pyramid, it was very much rest. We used to have patients coming into hospital purely for rest. And then beyond that, it was things like non-steroidals. And then beyond that, fairly weak immunomodulatory medications such as gold and hydroxychloroquine. And only the most severely affected were ever advanced onto the disease-modifying drugs that we use today. So the likes of methotrexate, which we use a lot of today, and azathioprine, which we use very little of for rheumatoid arthritis, if at all, were reserved very much to sort of end-stage disease. Now, we now know that that's not the way to treat rheumatoid arthritis, and we treat in a completely different fashion. So we want to treat aggressively. We want early introduction of immunosuppressive medication. We're no longer terrified of using methotrexate, so we would generally use this first line and escalate beyond this, along with using our allied health professionals such as physiotherapists and occupational therapists, judicious use of steroids and non-steroidals as well. So what's really changed with regards to this is a better understanding of what rheumatoid arthritis is. And this diagram here shows the sort of current accepted theory. So top left there, we can see an antigen presenting cell. So what we think happens is that there's an antigen, an arthritic antigen that comes along. We're not sure what these are. Smoking is definitely one of them. Gets taken up by the antigen presenting cell, and then the antigen presenting cell shows that to the T cell. And that's what starts this huge inflammatory cascade with B cell production, macrophage production, lots of cytokines being produced that have very potent inflammatory effects, such as TNF alpha and interleukin 6. This is then a very circular process and ends up with dysregulated cytokine production. And interestingly, when you look into the joint of a patient with rheumatoid arthritis, you do see an imbalance in the cytokines. So you see much more of the pro-inflammatory cytokines such as interleukin 6, TNF alpha, all of those ones listed there on the left, and much less of the anti-inflammatory cytokines, particularly things like the interleukin-1 receptor antagonist, interleukin 13, for example. So there's an imbalance. And one of the goals of the therapy we're using these days, particularly the targeted therapy, is to try and restore some of this balance. So I like this schematic because this very much shows how far we've come in terms of therapy. So from left to right, going right back to the 1930s, when all we had were things like gold and non-steroidals, through to the induction of steroids, methotrexate coming along in the 1980s. But it really wasn't until the very late 1990s that things really changed. And that was with the introduction of the targeted therapy. So initially, the anti-TNF agents, etanercept and infliximab, shortly followed by adalimumab. And since then, we've had not only an increase in anti-TNF agents, but other agents that, unlike the older agents, are much more targeted in how they're impacting the cytokine dysregulation and the cells they have an effect on. And the nice thing about treating rheumatoid arthritis is that the story doesn't end here. There are more and more therapies still coming through with different mechanisms of action. So these days in the treatment of rheumatoid arthritis, there are two big concepts that we try to follow. So one is this concept of a window of opportunity. So this is very much, we know that if we diagnose a patient early and we treat early, then this will hopefully prevent irreversible joint damage. We know that the longer a disease is present, the more damage is going to occur, and that cannot be reversed with medication. And it's harder to treat. And then you start to get more and more of those extra articular manifestations that can be just as impactful as the arthritis itself. And in addition to this window of opportunity, there's another concept that we use these days, and that's called treat to target. So that's about when you first see that patient with rheumatoid arthritis, you identify a target that you want to get that patient to. And we review those patients regularly until we've achieved that target. And ideally, that target should be disease remission. But in some patients over time, you may decide to come up with a slightly different target. But initially, we should be seeing patients as regularly as possible and trying to get them into disease remission, which I'll come on to. The reason why we use this approach, there is some evidence to back this up. So this graph here is from a study called the Tariff study. This was a study done in Glasgow in the early 2000s. And this was taking patients presenting to a rheumatoid arthritis service with new onset rheumatoid and randomizing them either to routine care at that period of time or intensive outpatient management. And in intensive outpatient management, that was identifying a target, aiming for remission, seeing patients much more regularly than previously, much earlier use of disease-modifying drugs, increasing the dose of disease-modifying drugs more quickly. And as you can see here, we've got disease activity scores on the y-axis. You can see that those patients with the black diamonds, by 18 months, they had a much lower disease activity score in the intensive group than those patients who had just been given routine care. So there's some evidence to underpin this treat to target window of opportunity concept. Now here we can see the general pharmaceutical management options we have for the treatment of rheumatoid arthritis. So we have non-steroidals and corticosteroids, which very much have their place, but should not be considered long-term options. We then on the left have the non-biological DMARDs, sometimes called the conventional systemic DMARDs, methotrexate, hydroxychloroquine, leflunomide and sulfasalazine. Gold used to be used a lot in the past. It's not used anymore. And in fact, they've stopped making gold as of this year. Penicillamine and cyclosporin also used very sparingly. And then on the right here, we have the newer drugs, the more exciting drugs, the targeted drugs. So the biological DMARDs or BDMARDs, which I'll talk about. And then more recently, novel oral therapies or targeted systemic DMARDs, which again, I will talk about. So in terms of biological therapies for rheumatoid arthritis, we have four main groups here, and these are all acting in different parts of this inflammatory cascade. So I said earlier that the process seems to start by activating T cells. So we have a drug, abatacept, that stops your T cells from being fully activated. T cells then go on to activate B cells, which cause all manner of autoantibody production. And we have a drug, Rituximab, that stops B cell activation. We know there's a lot of cytokines and pro-inflammatory cytokines involved in the pathogenesis of rheumatoid arthritis. And now we have drugs such as TNF-alpha inhibitors and interleukin-6 inhibitors that block the effect of these pro-inflammatory cytokines. So we have a number of drugs acting at different parts of this inflammatory cascade. And I'm just going to go through them very quickly. So to start with, we have the TNF alpha blockers. Now, these aren't new. These are now 20 years old. So it was 1999 that etanercept was first licensed by the FDA in America. We have 5 to choose from. There's no head-to-head evidence that any one is better than the other. They all have slightly different dosing frequencies and slightly different structures. Now, these have been around for a long time. The only thing that's changed really with these is we've now had the introduction of biosimilar preparations of some of the old branded anti-TNF agents. So adalimumab, etanercept, and infliximab have essentially now lost their patent, which means other companies can come along and they make biosimilar preparations that have to be proven in clinical trials to show similar efficacy and safety to the original branded product. And the main impact that has had is that the price has massively fallen. So up until a few years ago, these anti-TNF agents were around the price of £9,000 to £10,000 per year. Now with the biosimilar preparations, the price has fallen to between sort of £2,000 to £3,000 per year for those drugs where you do have biosimilar agents available. Rheumatologists still, even with these new therapies, we still regard methotrexate as the backbone of our treatment, and particularly with anti-TNF agents, they work much better when given in combination with methotrexate for reasons we don't fully understand. And this is shown here by one of these graphs. As you can see, the ACR 70 score means a 70% improvement. And as you can see, going back to these original studies with etanercept, the ACR score improvements were higher when given in combination than when etanercept was either given on its own or with methotrexate on its own. So any patient on anti-TNF or any biologic, really, we do try and give that in conjunction with methotrexate if at all possible, although many patients don't get on with that particular product. So moving on to rituximab. Rituximab works differently. So rituximab is a monoclonal antibody that binds to a very specific surface marker on B cells called CD20. And when it binds to this surface marker, it leads to the cell death. As you can see here, not all B cells possess CD20. So your pro B cells and your plasma cells do not possess CD20. And that's very important because if we were to wipe them out, you'd lose all your B cell memory, and that would put you at very high risk of infection. You wouldn't be able to mount any antibody response. Rituximab has an interesting history in that it was really invented and licensed for non-Hodgkin lymphoma back in the 1970s, but evidence was accrued since then to show it did have an effect in rheumatoid arthritis, and it was launched in 2006 for this condition. Again, rituximab is now an old product, and now we have biosimilar preparations of this available as well, launched a couple of years ago. So the price of rituximab has also fallen dramatically. How does B-cell therapy work in rheumatoid arthritis? Well, B cells have numerous roles. So if you block them or destroy those cells, they cannot do this. So B cells can no longer act as antigen-presenting cells to activate T cells. They can't then produce rheumatoid factor, which we know has pathogenic effects, and they can't release cytokines. Interestingly, and as you might expect, because rituximab is acting primarily on B cells, it works much more effectively in patients who are seropositive, i.e. those patients who are producing a lot of rheumatoid factor antibody, and also in those taking methotrexate. Moving on to our third mechanism of biological effect, we have interleukin-6 receptor blockade. So interleukin-6 is a very pro-inflammatory cytokine. It has huge far-reaching effects, as you can see here on the left. It affects things like your osteoclasts, leading to osteoclastic activation and osteoporosis. It affects your immunoglobulin production. It affects your liver, so it impacts on your liver's production of CRP and fibrinogen. it affects your platelets, it has far-reaching effects, but is generally pro-inflammatory. And we now have 2 interleukin-6 receptor blockers, one called tocilizumab, which is now over a decade old, and more recently sarilumab. These are either human or humanized antibodies against the interleukin-6 receptor. It's important just to make a note of these because interleukin-6 is pivotal in your production of CRP, and also your production of fibrinogen, which will have an impact on your ESR. If you give patients these blockers, their CRP and ESR will generally be normal, even if that patient has significant sepsis. So a take-home message is anybody on one of these interleukin-6 receptor drugs, you can't be reassured that their CRP and ESR are normal in someone who you're suspecting may have an infection. And our 4th mechanism, and probably the most complicated one, is regarding T-cell co-stimulation blockade. So to activate a T-cell, it needs 2 signals from an antigen-presenting cell. The first signal is the antigen-presenting cell presents the antigen in association with MHC to the T-cell receptor. And that's one form of activation, but that on itself won't fully activate your T-cell. You need the second signal, and that's the antigen-presenting cell presenting either CD80 or 86, which binds to CD28 on the T-cell. Sorry, a bit of immunology there. Now, we know that there's a naturally occurring inhibitor to this CD80-86 binding, so the left-hand binding, called CTLA4. And we now have a fusion protein called abatacept, which mimics that naturally occurring inhibitor, CTLA4, and binds to CD80 and 86. So it stops your T cells from being fully activated. And then this stops those ongoing T cell effects. You know, we said the rheumatoid arthritis seems to start with T cell activation. So this inhibits things right at the very sort of entry point of that inflammatory cascade. So they are the main biological drugs we have up our sleeve. Now, more recently, we've had some new products, and these are not strictly biologics. These are called targeted synthetic disease-modifying agents, or JAK kinase inhibitors. Now, JAK kinases are intracellular tyrosine kinases that generally occur in pairs linked to certain receptors, and they're involved in the signaling from a surface receptor to the nucleus of that cell. So for example, a cytokine such as interleukin-6 will bind to its surface receptor. But for that pro-inflammatory signal to go from the surface receptor to the nucleus of the cell to actually cause its effect requires activation of these JAK kinase molecules, which in turn lead to activation of molecules called STATs. And it's these STATs that then pass into the nucleus and exert the effect. So we now have drugs coming through, and these are the newest drugs that have been available, that inhibit these JAK enzymes, these Janus kinase enzymes. So these have been around for a couple of years now. They have several pluses in that they're oral medications. So all of the biologics that I've spoken about thus far are either injections or infusions, which obviously have big impacts on patients' day-to-day activities, particularly infusions, which require obviously a hospital appointment. So these are oral, very convenient. They're generally administered either once a day or twice a day. They're not, strictly speaking, biologically produced, but head-to-head studies against biologics have shown at least non-inferiority. They have much shorter half-lives than your average biologics. So most JAK inhibitors, the half-life is around 12 hours, whereas the shortest half-life for any of the other biologics is 2 to 3 days. So that might have an impact on someone leading up to surgery if you're thinking about needing to stop a drug quickly, or patients who are maybe more prone to infection, where you'd want them to be able to eliminate a drug more rapidly if they got an infection. And finally, there's some evidence to suggest that these drugs act more quickly than their biologic counterparts. We have 3 drugs now available. They all end in inib. So we have tofacitinib, which selectively inhibits JAK1 and JAK3. This had a bit of a rocky road to start with. It was licensed by the FDA back in 2012, but it was rejected in Europe because of its link with higher rates of herpes zoster. But it has finally been approved 3 years ago. We have a drug called baricitinib, which selectively inhibits JAK1 and JAK2 in preference to the other 2. again licensed in 2017. And most recently, we have a drug called upadacitinib, which is a selective inhibitor of JAK1. This has only been EMA approved last year and is still waiting NICE approval. So use of this drug is limited. These drugs are selective for the different JAK pathways, but if given at a high enough dose, they tend to lose their selectivity and would end up interacting with all the 4 JAK enzymes. We're not really sure if it's the importance of the different effects of blocking different JAK pathways, and certainly there are no head-to-head studies of these different JAK inhibitors at this moment in time. Hopefully with real-world data, we may be able to disentangle some of the different benefits of blocking, say, JAK1 instead of JAK1 and 2, but we don't know that for certain yet. So what are we aiming for in terms of rheumatoid arthritis? Well, we're aiming for remission. But what does that mean really in rheumatology? And this almost would be a talk in itself. If you asked 100 rheumatologists what remission means, they'd all give you a slightly different answer. So in the UK, the most common way that we would measure remission clinically is something called a DAS-28 score. So this is when a patient comes along, we assess the number of tender joints they have, and the ones we check are given on this homunculus here. We assess the number of swollen joints we have, we input their ESR, and then we ask the patient on a 0 to 100 scale, how badly has their rheumatoid arthritis affected their life over the last week or so? And you can put this into a calculator. There's a very complicated formula, and it gives this patient a score. And we would define someone being in remission if their DAS-28 is less than 2.6. And you can see on the left the different scores we have. Now, instantly, you might look at that and think, well, that's automatically flawed because you're ignoring the patient's feet. And many patients have significant inflammation in their feet. And also, it's heavily weighted by ESR, which can be influenced by other factors, and also the patient's opinion on their health. So a patient with fibromyalgia with lots of chronic pain will automatically give themselves a much higher score, artificially elevating their DAS score. But that's a measure that is easily performed in clinic, and it is what we would use, and it's what NICE require us if we're trying to get patients onto biologics. Now, there are flaws in this, and there are other measures of remission that possibly are more accurate in truly measuring whether a patient is truly in remission, which I won't go into in great detail, but there are other scores out there that are mainly used for clinical trial purposes. Now, what's interesting, and this has been proven in several studies now, is that patients who we feel clinically are in remission have ongoing disease activity if you look by imaging. So this comes from a prospective cohort of 107 patients, and over 50% we thought were in a good remission. But actually, when you MRI'd them, nearly 96% had subtle ongoing synovitis. And of those in remission, 19% still had radiographic progression. And as I said earlier, that's the one thing we're trying to prevent. So there's now this concept of a shell model of remission, and almost going from a superficial to a deep remission. So you could see a patient and you might think they're in a clinical remission, but that might not be good enough. So it's then going on to image this patient. So we would use a lot of ultrasound in clinic. Have they got evidence of clinical remission plus imaging remission? And there's now a concept of taking that even further. Patients who have clinical and imaging remission, but also they've now become either rheumatoid factor or anti-CCP negative when they were previously positive. And you could argue that that immunological remission would be the deepest form of remission that that patient could get to. At this moment in time, it's not common practice to check for immunological remission because the data is still lacking, but it's a very interesting concept. Why are we interested in remission? Well, we know that patients in remission have better long-term outcomes. So this comes from a French study who looked at patients with early arthritis and followed them up over time. And as you can see on the right here, so the orange bars are patients who had sustained DAS remission, and the grey are those patients who had ongoing moderate disease. And we can see that the patients in the orange had higher, the percentage of patients had fewer missed work days and less worsening of their HAQ score, which gives an estimate of their functional ability. So essentially, patients who are in DAS remission had better functional ability over time than those patients who have been left in moderate disease and missed less work. So this is an algorithm of recommendations for actually managing rheumatoid arthritis. There are several organizations out there that have produced their recommendations. This comes from EULAR, which is the European League Against Rheumatism. The Americans also have a very similar one. So what they're saying here, they divide it up into 3 phases. So first phase, you make the diagnosis. If a patient has no contraindication to methotrexate, they should go on to that with short-term corticosteroids. If they do have a contraindication to methotrexate, for example, significant lung disease or significant hepatic dysfunction, an alternative oral DMARD could be used with steroid in the short term, remembering that the likes of methotrexate and all of the DMARDs take a while to work, whereas steroids will work quite quickly. It's then assessing that patient regularly, and at 3 months, have they achieved that target? Or have they improved at 3 months, and have they achieved a target, ideally of remission at 6 months? If no, you move on to stage 2. And what EULAR would say is that stage 2, you then look at that patient and see if they have poor prognostic factors present or absent. And they define poor prognostic factors, i.e. those patients who are going to do badly, they're going to erode more rapidly, are those patients with positive antibodies, early evidence of joint damage on imaging, high levels of disease activity, or if you failed 2 or more conventional DMARDs. If you have any of that, at this stage, EULAR would say go straight to a biologic or a JAK inhibitor. For those patients who may be a seronegative, they don't have any of the poor prognostic factors, EULAR would suggest at this stage you could change or switch to an alternative synthetic DMARD, and then you go back to phase 1 and repeat again. Again, you reassess that patient at 3 months and again at 6 months, and if they still haven't achieved the target despite being on a targeted therapy, you'd move into phase 3. And phase 3 would suggest, again, switching. So the beauty of the treatment nowadays, if we have so many different targeted therapies that act in completely different ways, that a patient may not respond to an anti-TNF, but that doesn't mean to say we're not going to be able to help them. We might switch them to Rituximab or a Bataset or a JAK. Continuing to try and reassess that patient every 3 to 6 months and aiming for disease remission. Unfortunately, the likelihood of getting remission gets less and less the more biologic therapies that you've tried. You have the best success of disease remission on your first biologic. Now, in the UK, we have NICE, which means that we cannot strictly follow the guidance being laid down by our European or American colleagues. So NICE have produced lots of guidance for us for rheumatoid arthritis. And in January of this year, they produced their updated quality standards, which are impactful. So NICE would suggest that if a patient goes to their GP with persistent synovitis affecting more than one joint, or the small joints of the hands or feet, they should be referred to rheumatology within 3 working days, so quickly, again, because of this window of opportunity. They then suggest that adults with active rheumatoid need to be started on a disease modifier within 6 weeks of referral. So not 6 weeks of seeing them, it's actually within 6 weeks of GP referral. And then they're suggesting all the usual education and helpline advice. So going hand in hand with this, we have something called our National Early Inflammatory Arthritis Audit. And this was launched back in sort of 2017. And it's a national audit to try and, it came around because it's identified that there are real pockets of difference across the UK in how rheumatoid arthritis was being managed. So it was trying to help standardize this and to try and improve the quality of care for patients living with inflammatory arthritis. So most rheumatology departments in the country will have joined up to this audit and will feed back to this audit, and we get information about our service, and we can use this to benchmark and hopefully use it as a tool to improve our services if it's shown that we are lacking. And linked with this, there's something called the best practice tariff. So if we see a patient within 3 weeks of referral, and if we refer them, this is with rheumatoid arthritis, if we put them in, get them into the audit within 3 weeks, and we start them on a disease modifier within 6 weeks, and we offer them education, and we document their disease activity score, and we document some patient-reported outcome measures, then this unlocks an extra pot of money called the best practice tariff. So this means that the CCGs, the commissioners, would give an additional payment of £130 for each patient seen on top of their other fee if we meet the target for that patient. So we know we can't cure rheumatoid arthritis. You know, it's an incurable inflammatory arthropathy. But we know that if we see patients early and we treat aggressively and we treat to target, and we might be able to get remission in these patients. And we have an array of powerful targeted drugs to treat rheumatoid. And we have the likes of NHS England and NICE laying down guidance and even incentivizing trusts to treat early and aggressively. So surely that's the job done. End of story. Well, not strictly true. So when you look to data being coming out of the audit, so this is data from the 2018 to 2019 year. So even with this, you know, departments trying to do this treat to target window of opportunity, by 3 months, only 37% of patients with early inflammatory arthritis were in remission. Now, hopefully that data will be improved upon, recent data coming through, but you know, that's still only a third of patients, bearing in mind we know that time is of an essence in this condition. And that's even worse if you look on a more kind of global scale. So this comes from a systematic review and meta-analysis about looking at the proportion of patients in remission. And this found that at 3 months, only 17% of patients were in DAS remission. I mean, the reassuring thing is that with time, remission rates do seem to increase. So by 2 years, 24% were in remission, but still, I think you'll agree that remission rates are really low. And this was looking at, the N here was 82,000 patients. I mean, this did include other countries outside of the Western Hemisphere. So South America was also included, which probably brings the numbers down, but I think it still shows there's a lot of work to be done here. Things are improving. So this comes from an Australian study that looked at rates of remission, low disease activity from 2009 to 2014. And as you can see here, the rates of remission did increase, and rates of moderate disease activity and high disease activity did increase over that 5-year period. And that was associated with an increased use of biological disease modifying drugs. So why are we struggling to get patients into remission? Well, there are several reasons and several theories. So if you look to the audit, this does give us some clues. So this is, you know, looking at practice in the UK. So only 41% of patients seen in a rheumatology service had been referred within 3 days by their GP. That had increased by 70% on the previous audit, hopefully due to better GP education and the introduction of better pathways, meaning that GPs can easily get in to see rheumatology quickly. Only 38% of patients were seen within 3 weeks by us. Again, that had come down from the previous audit. So the mean was 28 days. Remember, we should be seeing them within 21 days. So we're falling outside of that for a week. But that had improved. It was 34 days in the previous audit. And roughly only half the patients were started on a disease modifier within 6 weeks of referral. So I think this goes to show there's still a lot of work that can be done, both in secondary care to try and make sure we do see those GP referrals as quickly as possible. And then also in primary care to try and get the message across that we would, you know, if there's a suggestion of inflammatory arthritis, we'd rather that would be referred rather than a watch and wait. One of the other issues is that we cannot follow those guidance laid down by Europe or the US due to restrictions placed upon us by NICE. So as I showed you in the European guidance, potentially if you had rheumatoid arthritis, you'd go on to methotrexate, but if you hadn't responded, you could go straight onto a biologic or a JAK inhibitor. Unfortunately, in the UK, patients have to have severe disease and they have to have tried 2 non-biological disease modifying drugs before this opens the door to anything else, which delays things. Now, there's always been a hope that NICE will lower the threshold for biological eligibility, as I said before, the price of many biologics, particularly the older generation anti-TNFs and Rituximab, has fallen dramatically with the introduction of biosimilars. So when NICE did their cost effectiveness analysis all those years ago, this was based on a cost of these drugs costing about £9,000 a year, and now with biosimilar drugs it's £2,000 to £3,000 a year, but this hasn't happened so far. There's a hope that next year NICE may start to approve biologics for moderate disease. Nothing formally agreed yet, but that's our hope. Even without NICE though, and so in patients being treated aggressively with biological drugs, these patients don't all go into remission. So this is a bar graph looking at patients who have not responded to methotrexate and gone on to different biological therapies. And this is a comparison of the original clinical trials. And it's looking at the ACR70 response. So an ACR70 is a 70% improvement. We would, that would be a significant improvement. And even with these, amazing drugs, 80% of patients still don't get that ACR70 response. And that's sort of across the board from adalimumab, tocilizumab, rituximab, even the JAK inhibitors, tofacitinib. And if you've got a patient who's already failed on a biologic, so this kind of patient would have tried methotrexate, one biologic, and has moved on to something else, their rates of getting an ACR70 fall even further. So 80 to 90% of patients don't get a 70% improvement. So why is that? Well, is it that we're still using biologics too late? Is it the fact that we're making these patients try non-biological drugs first? So even in America and Europe, new rheumatoid will all get started on a non-biological rather than going straight onto a biologic. But if you look to the biological drug trials, you do get higher rates of remission seen in those trials where patients have gone from being methotrexate naive directly onto a biologic. And that's again across the board for anti-TNF agents, interleukin 6 blockers, rituximab, and the JAK inhibitors. Again, these drugs have a huge cost implication, and I think we're a long way away from ever thinking about using these drugs prior to methotrexate, but that may happen at some point. The other issue about why we're not achieving remission is that rheumatoid arthritis is complicated. There's more than just tender and swollen joints. So we know that fatigue is a huge issue. Ongoing pain that may not be inflammatory is a new issue. So, even with our treat to target approach and our, these expensive targeted drugs, lots of patients don't achieve remission because they have ongoing pain, which we think is often possibly nerve receptor or chronic pain. They have ongoing fatigue, they have functional disability, all of which will increase their disease activity score and take them outside of remission. And these are incredibly hard to address because things like fatigue and pain are multifactorial. Interestingly, they're never the primary endpoint of any of the randomized controlled trials when these drugs are launched, but they are having a higher, more attention is being paid to them in a sort of a secondary endpoint approach. There was some interesting work done by a group called NRAS, which is the National Rheumatoid Arthritis Society. So this is very much run by patients for patients. And they did a survey of over 1,000 patients and they put the question to them. It was all about what remission means to a patient. They said to a patient, what are your barriers to remission? And we can see here's what the patients reported. The biggest one was joint damage. They felt that, some had missed the boat, but also things like treatment side effects, that the drug just wasn't working for them. They're not seeing their doctors or healthcare providers regularly enough, late diagnosis, numerous factors. And interestingly, only 50% felt that the patient's achievement of personal goals mattered to their doctor. So clearly this shows that there's still a lot of work that we need to do as rheumatologists to try and find out what is important to patients. So one of the reasons patients felt they weren't achieving remission was that they had issues with their medication. So safety is a very important aspect of both the non-biological and the biological therapies. The British Society of Rheumatology have produced guidance, which is freely available online, both regarding the safety of the non-biologics and the biologics and how you should monitor patients on these therapies. Firstly, looking at the conventional systemic DMARDs, I think my overall summary is that serious side effects are rare. If you take methotrexate, patients are quite fearful of methotrexate because it's a drug that's still, it's still used for chemotherapy. It has a chemotherapy tag associated with it. So patients are quite wary of this. The most serious side effect is a methotrexate pneumonitis, which is almost an allergy type of pneumonitis that generally happens early on into methotrexate use, but can happen at any time. It presents with breathlessness, dry cough, and wheeze, and is a matter of medical importance. Patients with this need to seek early medical attention because it has a high rate of fatality. It was always thought that methotrexate actually led to interstitial pulmonary fibrosis, so long-term use made your lungs fibrose. And actually the evidence for this is pretty lacking. And more people these days are actually thinking that methotrexate probably doesn't cause this. Actually, it's your rheumatoid arthritis all along that's caused it. Hepatotoxicity and cirrhosis can be a problem, especially in long-term use, and hence why we monitor LFTs regularly, and also pancytopenia, and that's why we would monitor the full blood count regularly. Sulfasalazine is often thought of as a more milder agent to methotrexate, and I think that is true on many effects, and that it's more immunomodulatory rather than immunosuppressive. But one of the problems with it is patients can get a rash on it, and I've seen some very nasty cases of Stephen Johnson for patients on this. The other issue is pancytopenia. Hepatotoxicity can occur, but it tends to be early on in the introduction of this medication. It's almost like a hypersensitivity. So if a patient's been on sulfasalazine for some time, it's unlikely to start causing hepatotoxicity. Hydroxychloroquine is our other big sort of conventional systemic DMARD that we use. And we used to use a lot of hydroxychloroquine because it was considered very safe, don't really have to do any blood monitoring on it. It can cause photosensitivity, so patients need to be wary about going in the sun with it. The use of hydroxychloroquine has fallen recently, and this is because of hydroxychloroquine-induced retinopathy. It was always accepted that hydroxychloroquine was associated with this, but thought to be very, very rare. And certainly locally, we have seen very few cases of it. However, there was a study that came out from the American Journal of Ophthalmology showing that actually, if you follow these patients up, 7.5% have evidence of hydroxychloroquine retinopathy at 5 years and 20% at 20 years. And they've suggested lots of monitoring guidelines for patients with their eyes, which basically require ophthalmology input. And most ophthalmology services cannot cope with the sheer weight of patients on hydroxychloroquine. So I think as a community, there's been a move to use less hydroxychloroquine because I think we all agree that the retinopathy is very rare, but with these new guidance available, it's becoming more and more of a hassle. In terms of biologics, the biggest risk factor is infection. These drugs do increase your risk of infection across the board. This comes from a Lancet published meta-analysis taken a few years ago. And overall, the risk of using a standard biologic with or without a DMARD, well, there was a hazard ratio of 1.3. So it's basically increasing your risk of infection by around 30%. Interestingly, they managed to accrue some data on using combination biologics, which is something we never advocate, and that's because of an infection concern. And you can see that the hazard ratio here was 4.14. So combining biologics together increases your risk of infection by 400%. So patients going onto biologics need to be talked through about different infections, particularly opportunistic infections. So we know that anti-TNF agents are associated with TB reactivation. So patients have to be screened before they go onto these therapies. And any patient on a biologic that starts to present with unusual symptoms, always going through your mind should be, have they got some weird infection? There's always been a concern about biologics and malignancy, but actually the data for this is reassuring. Most countries across the world have registries where patients on biologics have been registered and followed up regularly. And it was initially when anti-TNF agents were first launched that there was a concern that these drugs might increase your risk of lymphoma because you're getting rid of the TNF sort of tumor surveillance mechanism. However, this hasn't been proven, and across the board, the different registries have shown no association with solid or blood malignancy on anti-TNF use. there's been some conflicting evidence with regards to skin malignancy, both melanoma and non-melanoma. The latest evidence suggests that there isn't a significant link, but there are still reports of an association. So I would just tell patients to be cautious in the sun. Rituximab, as I said before, it was invented to treat lymphoma and certain types of leukemia, so it's considered sort of safe in malignancy and is generally our go-to drug in a patient with rheumatoid arthritis who has malignancy issues, past history of malignancy, for example, or current malignancy. The data for all the other non-anti-TNF biologics, such as tocilizumab, the IL-6 blockers, the JAK inhibitors, is lacking, and we'll only really get evidence from that as time goes on with more real-world collection data. So what does the future hold? So I showed you the pyramid before. I mean, the future, it's hoped that we can adopt this approach. So early use of biologics. So maybe patients even going on to a biologic or JAK inhibitor at the get-go. The sort of holy grail for rheumatologists are biomarkers. So we have all these amazing drugs to play with, but what we're not very good at working out is which biologic or which JAK inhibitor will suit that patient. And what we're all after are some kind of biomarkers that would tell us that this patient will respond to anti-TNF, or this patient would never have responded to anti-TNF, you need to block their interleukin 6. Work is being done in that field, but I think we're a long way away from this. And hopefully you'd start a patient on a biologic and JAK early, plus or minus methotrexate, and then with time, you could gradually withdraw things away and eventually get patients into a drug-free remission, which I think is what we would all wish to achieve. So with that in mind, that's the end of my webinar. Thank you very much for listening. And I will pass you back to Adam and the organizers to see if there's any questions.
Thanks very much, Chris. That was a fantastic overview of a just very complex condition. You've stimulated a lot of questions, both on the chat function, also via our email. And so I've been trying to pull some themes together on that. You've actually gone a long way to answering quite a few of them, I'm pleased to say, as well, which is great. I'm going to open up really with a fairly broad question, if I may, which is to ask, with you as a rheumatologist who sees people with rheumatoid arthritis day in, day out, what do you find the most challenging aspect of treating patients with rheumatoid?
So I think there's two aspects I think are challenging. One, as I sort of alluded to, we have all these, we have lots of great drugs, we have lots of options available to us now, particularly, in the sort of targeted disease modifying biologic world. And I think we can say that when you've got that patient in front of you, most patients will respond to most biologics, but we're just not very accurate in working out of all the fancy toys we have, which would be the best drug for that patient who's failed on methotrexate. So I think, I would love to see biomarkers to try and make our use of targeted therapies a bit more judicious. The other challenge I always find are those patients who clearly have got rheumatoid arthritis and clearly you've improved things, but they're still struggling with overwhelming pain and fatigue. And they're really hard to treat, and it's trying to disentangle why do they still have these issues? Is this still part of their rheumatoid arthritis disease, or have they got other issues? And I think most services are not particularly very good at dealing with that. We generally have quite little psychological support. So I think it'd be, I think some more studies looking into that and maybe prioritizing things like fatigue and pain in primary endpoints for some of the randomized controlled trials would go a long way to try and help us work out how we can try and help patients with that. Because you ask a patient what's their main problem, they don't ever say swollen joints, it's always pain and it's always fatigue. They're huge problems for patients, and I think we probably underplay that treating them. Thank you.
This is a question really as a geriatrician, and I think for anyone who's involved in the medical take and general practitioners. A lot of patients we see, as you mentioned, the mainstay is methotrexate. Unfortunately, a very common drug we use is trimethoprim for the treatment of UTI.
Yeah.
If someone has stopped methotrexate, how long do you think is a reasonable washout time before we could safely start using trimethoprim again?
That's a tricky one. I don't think there's an accurate answer for that. I mean, I would say, at least 5 half-lives of methotrexate. So I'd want it to have been out of the system for, you know, possibly up to 3 months.
Yeah, so the longer the better, really.
Yeah, I mean, if you look to pregnancy, I mean, it's a teratogenic drug, and we say that ladies can start trying if they've stopped methotrexate 3 months in advance. So I guess by that we're saying we think the methotrexate's out of your system. So I guess the same would apply to any other sort of contraindication to methotrexate.
Okay, thank you. In terms of, there was a very interesting question via email, which was regarding peripheral neuropathy and rheumatoid arthritis.
Yeah.
And is there any evidence that you're aware of that really the better you control the disease itself, in the same way as diabetes, you may help to reduce those side effects of things like peripheral neuropathy? So, neuropathy from the disease rather than the drugs?
Yeah, I mean, so neuropathy would be an extra articular manifestation. So I guess ideally it's all about treating aggressively to stop patients developing neuropathy. I think once a patient has already got neuropathy, I think adding in biologics and things will hopefully at least halt it, but I doubt they would actually reverse it because of the damage that's there. I guess the other question is to work out actually, is the neuropathy due to kind of active vasculitis? So is there active inflammation causing the neuropathy, or is this now just damage? We see less and less of it, but I think the key is early treatment to prevent it. I think if a patient does have it, there's not a lot of evidence out there about it, but I suspect the drugs would at least halt it, but I'd be surprised if they dramatically improved it.
And there's another question about, well, how commonly do you see patients with rheumatoid arthritis who have actually very little in the way of joint disease, but present with some of the extra-articular manifestations? And then the sort of second question from that really is, if you do see that, are there some biologics which treat those extra-articular manifestations better than others?
Yeah, so occasionally we see it. So occasionally we get referrals from our respiratory consultants who've picked up some with interstitial lung disease, and as part of their workup, they've maybe picked up some autoantibodies, or, you know, they've started to ask the patient about their joints. Occasionally we've had patients, I've seen patients with rheumatoid nodules, just a rheumatoid nodule, which has been identified on biopsy and histology, but no obvious sign of rheumatoid arthritis. So it does happen, but it's rarer. It's rarer. I think generally these days most patients are presenting with the joints. Yes, there are some biologics that work better for extra articular things. So particularly, let me think. So so lung involvement. So the pulmonary fibrosis. Anti-TNF agents, there's always been a bit of a concern about anti-TNF, whether they cause pulmonary fibrosis. The data is lacking, but drugs like Rituximab and abatacept would probably be used more along the pulmonary fibrosis line than something like an anti-TNF. For eye involvement, generally anti-TNFs have better efficacy. So for things like uveitis and scleritis, probably anti-TNF. Yeah, that would be the main differential. Is mainly, I think, the lung and going more down a Rituximab, abatacept kind of route.
Thank you. Now, this wouldn't be a webinar without mentioning COVID at the moment.
Yeah.
And in terms of that, how has COVID changed your practice in the use of high-dose steroids to get on top of flares and things?
Yeah, I mean, it's changed massively. We know high-dose steroids are bad news at any point in time. We know that. I think I think COVID has really hammered home just how infection-inducing steroids can be. I think, you know, we're very good at, when we start patients on steroids, talking about osteoporosis and high blood pressure, and I think we underplay the infection risk. Yeah, so certainly early on in the COVID pandemic, we were very much avoiding steroid as much as possible. So we're avoiding depot, we're avoiding joint injections. But I think probably that's to the, you know, it's finding that balance, isn't it? It's very hard to just leave a patient struggling and say you can't have anything, because steroids are the only thing that will work quickly for them. I think as a rheumatology community, I think we probably use too high a dose of steroid. There's a lot of talk out there that actually, you know, not just rheumatoid, but lupus, we probably don't need to use quite as high a doses as we're kind of taught at medical students. So, you know, you don't need to give 30 milligrams, probably 15 milligrams would be fine. So I guess we're using less steroid. We're generally using lower dose steroid. And we're using it much more judiciously. So we really would only be using it in those patients who truly have ongoing active inflammation, whereas maybe before they were dished out slightly more freely for patients, you know, coming in for their intramuscular depomedrone kind of boost, you know, that's stopped.
Yeah. Okay, thank you. And just in the interest of time, this will be the final question I ask. This is quite a specialist field, but in terms of pregnancy,
yeah,
what do you feel is the safest of the drug combinations if someone's trying to become pregnant or is pregnant?
So, so methotrexate and leflunomide. So in terms of your conventional DMARDs, methotrexate and leflunomide are no-nos, teratogenic, associated with high rates of miscarriage. Sulfasalazine is safe in pregnancy, and hydroxychloroquine is safe in pregnancy all the way through. Steroids, yes, you can use them in pregnancy, but they are potentially associated with risks. In terms of biologics, actually one of the anti-TNFs is actually licensed for use in pregnancy, which is certolizumab, Cimzia. This is a pegylated anti-TNF. It's a large molecule, so it's been shown not to be actively pumped across the placenta. So there's really useful guidance from the British Society of Rheumatology all about the different drugs in pregnancy. So for that person who emailed in, it's really helpful. It's got a lovely table of the different pre-conception and the different trimesters and little ticks as to what you can and can't use. Essentially, certolizumab, which is an anti-TNF you could use all the way through. The other anti-TNFs we would generally let you use all the way through and stop in the 3rd trimester for concern about making the baby immunosuppressed, and you could then restart in breastfeeding. The non-anti-TNF biologics, we suggest you have to stop pre-conception. And I think a lot of that is because we just don't have the data. So it's not that we know they're teratogenic, it's just they haven't really been used to collect any data. So if a patient needs a biologic, it would be an anti-TNF, and ideally this one called certolizumab.
Okay, that's brilliant. Thanks ever so much. I'm going to draw the questions to a close there, Chris, but I want to thank you very much indeed for joining us this evening and for speaking. I think the audience would all agree that you've given us an absolutely fantastic overview of rheumatoid and also the modern treatments available to us now. It's one of those ever-changing conditions, isn't it, and with treatments around it. I'd like to also thank Chugai Pharmaceuticals for giving us sponsorship to make this evening easier. I'd also like to thank all of the guests for attending the webinar this evening. As I've mentioned previously, we're a small team here at UKGIM, but we're really keen to provide really high quality, free or inexpensive CPD to medical professionals. So if you've enjoyed this evening, I'd be grateful if you could mention UKGIM to your colleagues, or visit our website, which is ukgim.com. It'd be great to have as many of you attend our conference on the 2nd and 3rd of March 2021, which is now going to be a virtual event. Also, if you use social media, please like us on Facebook, have a look at us on Twitter. Anything you can do to spread the word for UKGIM, we'd be very, very grateful. I look forward to welcoming you to our next webinar, which is going to be on the 21st of October. And that's going to be on the challenges of management of patients who present to the medical take with Parkinson's disease. So perhaps as a new diagnosis, or people who have established Parkinson's disease and the treatments around that. That's going to be advertised again on the ukgim.com website. And all that remains is for me to wish you all a very pleasant evening. And I hope to see you all again soon on the 21st of October. So thank you very much and good night.